Thank you everyone for joining us on our monthly webinar. This is Chadi Alraies coming to you from Hard Trending. I'm really privileged to be with our this speaker for this month, Dr. Omar Khalique. Just before we get started, just a reminder, this is a 1 hour CME activity. So if you interested, please fill in the evaluation at the end, and we'll send you an email for CME. Two is this is very engaging. So if you have any question to the speaker, please throw it in the Q&A box, and we will be addressing those as we go. If there's a question relevant to the slide, we'll pause and we'll take that question, or otherwise we'll leave it to the end. These are webinars coming to you every third Thursday of the month. We have so far started in July, and thanks we have so far 7 or 8 of them. They're all recorded. Thanks again to the Facet, which is sponsoring this activity. They're based in Dallas, and this is a CME also provided by the Facet. Stony, thank you for helping us with this, as well as Katie Hobbs and the team for putting this together. With no further ado, we're going to today talk about multimodality imaging and invasive imaging for patients with structural heart disease. This is a very hard topic, and as we know, structural heart has been evolving since 2007, since the birth of the TAVR. But we're bringing an expert, Dr. Omar Khalique, who is the Director of Division of Cardiovascular Imaging, as well as Director of Advanced Cardiovascular Fellowship at the St. Francis Hospital in Catholic Health System of Long Island. He's also Professor of Clinical Cardiology at New York Institute of Technology and Director of Cardiovascular Imaging and Research at DeMatteis Cardiovascular Institute. And finally, he's the Director of Structural Heart Imaging Core Lab, CT Core Lab at CRF. Omar, so pleasure to see you again, my friend. We see you a lot in conferences, and now we overlap a lot of conferences, and thank you for doing this for us.
Sure, my pleasure. So we'll get straight into it. So I have some disclosures here, but the biggest one for this talk is that I'm a multimodality advanced cardiovascular imager and program director for an imaging fellowship with a lot of passion for this topic. So when I started training, nobody really knew what was a multimodality imager or an interventional imager. Now everyone needs one. Everyone needs reviews on multiple modalities. And as Chadi and many of my colleagues across the country give me weekly calls to ask me if there are any interventional echo people to hire. I think we know that this is a really growing field. So what is multimodality imaging? This is really the confluence as we interact with all of the different cardiac subspecialties, as well as those outside of cardiology. And we really are a connector, I feel, for all of these different groups. The newer paradigm is to have a patient-centered approach and to eliminate silos. So really using the best test for every patient. And you really need an imaging expert to do all of this. My division contains a number of cardiologists. It's a bit of a unique setup, full-time cardiologist imagers, and that's all we do. And we have 1, 2, 3, and 4 modality imagers in the group. The complexity of imaging has increased, although I'm not going to go through many trials in this talk. This is an indicator that the number of trials has significantly increased over time. The birth of the structural interventional imaging physician was with 2 of my mentors, Becky Hahn and Marty Leon, who coined this terminology many, many years ago, back in 2005 or 2007 as really a new subspecialty. So what is an interventional imager or an advanced imaging cardiologist? I would say level 3 in at least 1 modality, and then multimodality brings you to at least 2 modalities. There are many challenges in our field, which is a good background for this talk for everyone to be aware of. How to develop a multimodality imaging approach. So we know that silos are very common. These represent current barriers, which many of us face. Single modality cardiac imaging specialists now need to become familiar with many modalities because they're all very relevant in the clinical arena. And one of the biggest for us on a day-to-day basis is that most hospitals have separate structures for cardiology, radiology, sometimes nuclear medicine, and sometimes even between modalities. And this really encourages competition rather than collaboration. Training is also a huge issue. We really dislike the word non-invasive cardiologist because that's defined as a general cardiologist without extra training. What would be better is an advanced cardiac imaging physician, recognizing the extra training. This is getting really to a point with a lot of requirements, which is another challenge in this guideline for interventional echo. It's recommended to have 150 extra cases just to train for this subset of cardiac imaging. Advanced echocardiography, as an example, the knowledge has increased, I would say, by at least 10 times since I started because of all of the structural heart intervention. So it's becoming extremely exponentially more difficult to to really attain mastery during your general fellowship. And oftentimes advanced training is needed. And this is a hot take, but I think mastery of a single imaging modality is very difficult now to complete during a general cardiology fellowship because of the limited time that's given and the amount of knowledge that's now a prerequisite. Just as an example of a case I'll show later, just in a single case, we used ICE, TE, TTE, and IVUS, and that was for a structural heart intervention, Sesame. And that's just in one single modality, which is cardiac ultrasound. Now, all of these guidelines are coming out on training with all these different numbers. And just as an example, if you want to get level 3 times 4 modalities with the current training guidelines, you need 33 months and 2,100 studies, which seems impossible. So we need much better pathways. Another thing that goes along with this is being overboarded. This is all the boards that we take, amounting to a lot of money in addition to the time and opportunity cost of studying. And in addition, we are one of only 2 subspecialties in cardiology that's not ACGME and thus not recognized in salary surveys as a specific advanced group. Challenges for trainees are to get exposure with the limited time in their fellowships, particularly with CT and MRI with radiology run programs. Another challenge is that there's a lot more requirements for cardiologists to supposedly be proficient versus radiologists. Employment challenges, burnout is a big one, which is talked about in many different fields now. Reimbursement is another for interventional echo, where there's a huge discrepancy between the procedural operator and the interventional echo doctor of multiple fold. And another big one that's coming up, which we'll touch on, is that currently within the rules, the echocardiographer, even if they're involved, cannot bill for an ICE procedure. This creates this kind of vicious cycle of having low salaries, burnout, too many boards, expense. Then cardiology fellows who are very smart don't get interested in the field because they don't want to deal with all of this. And then we have a continued lack of qualified trained cardiologists for advanced imaging. Here we see that on this chart, which I created, that the number of fellowship trainees per year is very low compared to other subspecialties such as EP and interventional echocardiography, interventional cardiology, and the number of board certifications is higher. So this is really creating a bottleneck in the current environment. And this is just something I made up, but it's an example of the ways we need to evolve in our training pathways, perhaps providing more training in the general fellowship, more time to get specialized on a pathway to a career in advanced imaging so that the number of years spent overall could be reduced. So that was the price of entry to this talk, my spiel. Now we'll talk about the actual imaging part, which Chadi invited me for.
So Omar, before you go there, I mean, I think there's some
Sure.
team on the call. Are there fellows or trainees? So most of them are not aware of this track in terms of advanced training and imaging, and they don't see the value is because of fear of they have to be protected by the employer because, as you said, they get into a long case, 2 to 3 hours, versus somebody in private practice kind of doing 20 echoes in that time. So they get worried about finding the perfect job or not having a protected institution or department to do what they are loving to do. And they don't want to waste a whole year and then struggle to find a job or find the right setup. How do we balance these two things?
So it's tough. Of course, I don't want to discourage people because we need to hire more people as well. I think we have a very good setup, but you're absolutely right. I think number one, people aren't exposed to real cardiac imaging during their general fellowship, so they don't really know what it is, and they have a different view of it. Number two, once they get exposed, they face the problems that you're describing. On the positive side, I think it's slowly changing, but it's a fight. So it's tough for hospital administrators to really understand what we do and why we don't produce as many RVUs, with imaging studies being reimbursed low in general. And then, as you said, once you introduce interventional echo, then your RVUs plummet. But many people reach out to me with these questions to try to convince their jobs and everything else. And I think the real message is that you can't do all of the advanced procedures without interventional imaging. So whatever money that Watchman's make and LA appendages and TAVRs and whatever else, it really can't be done without us. So it has to be some type of a shared model or at least shared understanding.
Yeah, makes sense.
So we're going to start with just diagnosis before we get into the interventions, because this is really where everything starts. And there's some things that are good to be aware of. So I think in the current time, with the history has been that the echo guidelines call things severe by echo based on various metrics and cutoffs. And most of those are arbitrary, to be honest, and based on very old data, sometimes 30, 40 years old, which really is not very robust. So there is a movement now to move away from this severe rating towards significant. So what does significant mean? That means prognostic cutoffs that are gaining traction based on new literature. These thresholds are being defined as we move along and continue to be. And in the latest era, I think cardiac MRI is a key modality that's really shown benefit in terms of showing prognosis at least. So what are the main tools here? Volumetric imaging, so getting your Simpsons from actually a short axis stack, and then your phase contrast, which is direct flow imaging. Here's an example of volumetric imaging. So you see very clear images, very reproducible. So you get your LV and RV and diastolic and systolic volumes, and you get stroke volumes from that, as well as your volumes. Here we have phase contrast imaging, which is similar to a Doppler and echo, but it's a direct measurement of forward and backward flow. And then using these various techniques, we can do some calculations, trying to get a parametric, multi-parametric agreement, and we come up with a severity. A part of this, which I showed as one of the calculations in the previous slide, which is newer, but is not research, this is in the clinical arena, is a 4D flow where we can take away some of the assumptions and directly measure flows in a fashion and use NPRs and things to align ourselves better. Now, there's been pretty robust data on MRI in the aortic regurgitation field. This is one such study showing decline of prognosis with a regurgitant fraction above 32%. And this has been consistent in several studies in a row in various forms. And just as a comparator, the echo guidelines say that you have to be above 50% to be severe. So there's quite a big discrepancy, and we've seen this in some of the clinical trials on TAVR and AR. But this is something that's gaining a lot of traction to really change, as we're really undertreating patients by not identifying things early enough. In TR, there have been similar papers. This is one by Deep and Shaw, the group in Houston Methodist, showing by prognosis what are the cutoffs for regurgitant fraction and volume stratified by cardiac MRI quantification. Another thing that we're trying to understand better is RV ejection fraction in the setting of tricuspid regurgitation. So what does that mean? This is an example of two different patients. The one on the left and the right both have a quote stroke volume of 50 mLs, but the one on the left has no regurgitation, so that their forward stroke volume is 50, and their EF is 50%. The one on the right also has a stroke volume of 50, but half of it's going forwards and half is going backwards. So really their EF is 50, but it's a pseudo-normal RV ejection fraction. And when you calculate something called effective ejection fraction, the left is 50% and the right is only 25%. So the calculation for effective RVEF would be forward flow divided by RV end diastolic volume. And that's really your cardiac output rather than just what's being ejected in both directions from the RV, which overestimates the EF. And we know from natural history and surgical studies that this has a better correlation than other factors with prediction of outcomes from either natural history or a surgical correction procedure. Now moving into the various structural heart procedures, which we're going to talk about. We'll touch on all of these: TAVR, LA appendage, tricuspid, mitral, and electrosurgery. So aortic annulus, we all know this is a basic measurement for TAVR, most often done by CT. Here's something we published years ago showing a good correlation and agreement with 3D TE in patients who couldn't get CT. Another approach, this is a recent case study from case report from St. Francis of using MRA, and you can use either contrast or non-contrast. Contrast is a little clearer in terms of the signal, but requires a longer imaging time. Non-contrast is a little more blurry, but shorter imaging time. So this was a case in a patient with severe renal dysfunction bordering on dialysis, where the nephrologist didn't want to give any CT iodine contrast. So we did a series of studies. We did a non-contrast CT just to look at the calcium, which is really a strength of CT. And then we did various forms of non-contrast MRI and MRA to do our annular measurements, our sinus, and our coronary heights. Recently, a couple years ago, we faced this lockdown of dye, which we experienced. And these would be the various scenarios where you could use the MRA technique. Here's an example of appendage, which we also did during that time. But contrast shortage, iodine allergy, and severe CKD, it could be all indications to push you towards using MRI. The next wave, as I mentioned, for TAVR, we're very familiar with AS, and there are a lot of devices. This was the Align AR, which was the first trial really studying, pivotal trial studying TAVR in pure aortic regurgitation. And this was a positive trial with good outcomes. And we're hoping for approval coming soon. There's another device, also J-valve for pure aortic regurgitation. And there are quite a few of these patients, and this is really an unmet need. LA appendage is a big topic nowadays. The pre-imaging, I think there's not as much of a question, so I'm going to focus mostly on the post-imaging, where we get tons of questions. So the two current devices approved by the FDA in the US are the Amulet and the Watchman. So here are some examples of cardiac CT peri-device leaks. So this has become a fairly complicated subject, not only in terms of the imaging and identifying, but also how to report these. So you can have peri-device leak, intra-device leak, mixed leak. And what we know now from the literature is that leaks are detected more frequently with CT than TE. And that's because contrast can diffuse through small spaces. But some of these may be, quote, clinically relevant versus irrelevant. We had this nice study from Mo Al-Khalique and the Mayo, from the Mayo group using the NCDR registry. And they really looked at this large group of over 50,000 patients. And what they found is that actually any leaks were associated with a signal for stroke, non-disabling, but there was a signal. And actually in the large leak group, there was a lower signal, and that's the reason being that people probably put them on anticoagulation. But this really put up a warning for everyone where we were just kind of thinking that these small leaks don't really matter. Now we're looking at all of these post CTs and imaging tests more closely. Here's an example of a normal post LAO CT. You see that the device is fully thrombosed, which if you have a complete seal, it should be. There's no contrast inside. It has good seating, looks well compressed, and there's no device-related thrombus. And you can get much more complex scenarios with abnormalities. So here you see that there's very little thrombosis in the device, which means it's not sealed. The face of the device, you can see here, has a lot of sparing, which means there could be incomplete endothelialization through the face. This is a deep implant, which you see on this middle image with probably big gaps and leaks on both sides, but there's no DRT here. And this becomes a big question and a challenge in reporting. This is an example of a combined DRT. So you see this here, device-related thrombus and a big leak on one side. So we're starting to see all of these different complications. So if all leaks matter, now we need to move beyond size of the leak only and try to figure out what is the significance of the different types of leaks. And at the current time, we don't really know, but people are starting to look into it. And this is a schematic I created just showing the various types you could have. So on the left, you could have a peri-device pocket, which is not really a leak. It's just a gutter, which we commonly see. However, if that gutter transcends and goes below the fabric of your LA occluder, you can have a through metal leak, which there is actually a gap between the appendage and the left atrium. You can have a through fabric leak, which could be just a micro leak, which contrast can get through due to incomplete endothelium, but probably nothing can really get out of the appendage. And then you can have a frank peri-device leak, which is the classic kind that most people see. Here's an example of something we're starting to do with the increased index of suspicion, but presumably these large leaks need to be closed. This is an 11 by 5 millimeter leak. And this is some of the CT planning and sizing we did before the procedure. Here's an example of an en-face view. So we planned the fluoroscopic views from the procedure. Here's a side view at an LAO caudal. This is where you would see it, the device on the side. And a little bit of tough imaging on this case, but we got this into the side of the device, side of the Watchman. And you can see it here on the right-hand panel that we sealed the leak within the gap. Another big topic for LA appendage and also tricuspid is ICE. And the recent SKY-HRS expert consensus recommended a slow startup with ICE combined with TE while you get experience and then transitioning to ICE if desired. But I think the cardiac CT pre-planning is going to become increasingly important as the intraprocedural imaging becomes more minimalistic. And there is possibly a potential for more leaks because the imaging just isn't as good. So what's driving ICE? The use is definitely growing. It's still not a comparable technology to 3D TE, so there's a possibility of missing leaks. And the push for ICE, I think, is driven not only by patient care pathways, but also by the lack of available imaging specialists. I think that's a huge factor. People don't have those imagers as resources. But we have to keep in mind that it really provides only a fraction of the information from TE, which has been the standard during cases for quite a long time. So you have to be a little bit careful. Moving on to some tricuspid interventions. I just want to go through a case rather than lecturing.
Omar, before we go to that, the tricuspid, we hear it a lot about the pre-left atrial appendage occluder planning, CT versus TEE. And is CT is enough for measurement as well as to exclude the clot rather than subjecting the patient for TE before the procedure and then at the day of the procedure?
So yeah, so I think CT is better. We're about 99% CT imaging for the pre-planning. And the reasons are several. One is for us, the workflow is much easier. I think patients like it better, as you mentioned, just going through a scanner versus having a big tube inserted. And then CT, quite frankly, you see the anatomy much better. There are a lot of distal lobes and complex anatomies you miss on TE because of the shadowing. And they're only revealed on CT. So you really don't know what you're getting into when you go into the case. And it has, by the literature, an equal accuracy for excluding thrombus as long as you're using the correct CT protocols, which would include not only the first pass CT, but a delayed scan at 30 to 60 seconds. So there's very, very few cases where you can't rule out that way. And for those few cases, we use prone imaging. So if we have a persistent defect on the delay image, we turn the patient on their belly and we do another image where the contrast will sink to the tip of the appendage, which will then be facing down, with contrast being more dense than blood. So, I mean, I remember hardly any cases where we had to, quote, clear it on a TE, which I don't think is necessarily any better.
So it depends on the scanner, but also on, more important, on the protocol.
Yeah, that any scanner can do it, but it's more the protocol. You have to do the protocol correctly.
Got it. Okay. So that's very convenient for the patient and procedure planning. And so you have only one time TE.
Exactly.
Yeah. Thank you.
So for tricuspid, we now have, as of the past several months, we have two approved devices in the US. One is the Edwards Evoke, the other is the Abbott TriClip for edge-to-edge repair. But I'm going to go through this case. So this is a 3DT, which was done for tricuspid assessment. Here you see our biplane and 3D image. Sorry for the sound. Here's just an example of the measurement of the annulus on ComTech. And by echo, this was about 44 by 38, which is within the range for a transcatheter replacement. And here you see the quantification of the TR by 3D vena contracta area. So just using our 3D color Doppler and our multiplanar reconstruction. And here we got 151 millimeters squared. So if you look at the expanded TR grading scheme, it's definitely severe, but it's actually in the torrential, the highest category. And here on the CT for some of the pre-planning, since we were leaning towards replacement with the gaps on T looking pretty large, where an edge-to-edge device may not reach. We can see here that there's a pacer lead. It appears to be sitting in the septal posterior commissure. And one of the things we look for is that it doesn't look adhered and it has some slack, so it's not a tight lead, which we may displace. So it looked like a good candidate here. And you can see on this upper left-hand image at the tips of the tricuspid valve, you can actually see the very large gaps that are there between the leaflets. So on the CT, the annulus measurement was 48 by 39, a little bit larger than the TE, which is typical, as the patients are not fasted for the CT, but for the TE, they're under some type of anesthesia, and they're also fasted for the day of, but still within the range of a device. And some of the other newer measurements we like to do the offset. So from the IVC, how far over is the center of the tricuspid annulus, because that's the bend our catheter has to take. 18 millimeters is pretty average to small. And then what is the angle from our IVC coming into the trajectory of our tricuspid valve? Sometimes this can be very steep or unusual. This is 70, which is a little bit acute, but within the normal range. Here we can see from the CT, looking at the leaflets, that they're unremarkable. They're mildly thickened with some tethering, so no major red flags there in terms of hooking on to the leaflets with the device. Tips for anatomic orientation for the tricuspid. Septal leaflet is next to the septum. Anterior leaflet is next to the aortic root. Posterior is opposite from the aorta. At the coronary sinus is typically the septal posterior commissure with a little bit of variation. And then just to note, there can be various subtypes of tricuspid leaflets with subscallops, more than 3 leaflets. That's very common. and there's literature on that as well. For the procedural imaging, here's our 2D biplane. It's non-coaxial, a bit suboptimal. We were able to coaxially guide the wire. We have 3DT NPR, so that we're taking our non-coaxial image and we're through 3D, we're actually realigning it for ourselves so we can see everything the way we like it. And here is the device, which is a 3D NPR, so you have to circle round and round to see all of the leaflets, and I'll show you in a second. So here's the rotation of the device. So it has 9 arms, and we have to circle all the way around here and see each one of these arms grabbing a leaflet. And this is what comprises most of the procedural time. So on the initial attempt, we felt there was a little bit of suboptimal quality. Leaflet visualization was a bit unclear on the 3DT NPR. We, for our tricuspid cases, we keep ice on hand for exactly these situations. So here's 3D ice with the Verisight. We have better leaflet visualization. You can see on the right-hand screen, upper right, we can see the pacer lead very well, and we have to make sure we're grasping the leaflet around it. And then we are realigning the device, which we see here, the arms starting to open in our upper left view. Just to be aware of with the Verisight, at least the 3D ice, we want to be in the green or blue imaging planes with the long axis with the most elements of the device for optimal imaging. Once you get into the short row of elements, image quality can degrade, so something to be aware of. So after we did the ice, our T imaging improved, which sometimes happens just from having different positions. We were still off axis, but here we thought we had mostly captured the leaflets. And we used our 3D NPR again. So you see we're switching back and forth between 3D ice and 3DT. So we verified again here as we rotate it around. Here we can actually see the arms better now on the 3DT in both views. And you can see now we're starting to isolate these leaflets falling onto every arm. And you can double and triple check this just to make sure. We can see also our pacer lead on the upper left being sequestered the way we want it to be. And here we're back to 3D ice for some more up close imaging, really to isolate that leaflet and arm right next to the pacer lead just to triple check. So every device arm was confirmed under the leaflet by rotating the NPR, and the device was deployed. So again, on the T, there was a lack of alignment. We need to assess the device here. We did do a 3D color image over here. But then we ended up going back to the 3D ice just to get imaging, which was a little better. And you see on the right hand, we see some trivial PVL at the red arrow. And just as a comparison, here's the angle of the fluoro compared to what we predicted on the CT. So it looks pretty similar. I want to touch here on electrosurgery. My colleague, Jafar Khan, is a co-inventor of many of these procedures. So pretty exciting. He likes to be electrocuted. This is a case of sesame, which is septal scoring along the midline endocardium. And it's a septal reduction technique. So we retrograde, put in a wire, insert it through the myocardium at the basal septum, snare it, electrify the wire, pull back, and create a myotomy, which is basically a cut which splits a portion of the septum. Here in an animal is what an intraprocedural CT would look like, just to give you an idea. Here's the case, an 81-year-old female, severe symptomatic MS, evaluated for mitral valve and MAC and needed septal reduction. So here's the CT after the first technique, which was alcohol ablation. Our neo-LVOT area increased from the initial, which was 42, now up to 147, which was still below the cutoff of 150 to 180, so we needed to increase more. We moved on to the Sesame procedure over here. And this was the case I showed where we used all of our different ultrasound modalities to first identify the entry point in the basal septum near the aortic valve, and then this is a TT to identify the path of the wire through the basal septum at the depth we had planned, which was usually half the depth of the entire septum. Here's an example of the intraprocedural study. Once we cut the septum, there's a little V-shaped cut in the interventricular septum, which widens over time. And here's the post-follow-up CT several weeks later, showing the gap that we created. So we created a little more space, now up from 140s to 180. Next, we moved on to doing a lampoon. This is a midline laceration of the anterior mitral leaflet. We see the snared wires here. We made a cut and successfully inserted the valve and MAC TMVR. I want to talk about some new technologies, including computer simulation, photon counting, and holography. So there are some computer simulation vendors now, which beyond just putting in a static virtual device into some regular software programs, they do finite element analysis and modeling, trying to predict the behavior of your device in complex cases such as this valve and MAC. This is FEOPS. Another one is DASI simulations. This is also a valve and MAC case. We have had actually one randomized study of computational modeling in LA appendage amulet insertion. And what this showed was that with computational modeling, there was 40% increase in complete LA closure with no leaks on follow-up, and lower risks of device-related thrombus and lower risks of device migration as well. You can see up top, total number of closure devices used was less, repositionings less use of radiation and contrast during the case. Photon counting CT is an exciting new technology. Here's an example of a 30 cc TAVR CT. Here's the original reconstruction. With photon counting technology, we can inherently change the energy displayed in the scan to get an image on the right, which is from the same patient. And this is the cine from the same patient, and I don't think you would be able to tell this was a 30 cc TAVR unless I had told you. It's a very good image quality and super enhancement of the iodine contrast. And in the post-TAVR world, also very useful, very clear imaging, reduced blooming of the stent frames, ability to see halt, which ends up occurring close to the stent frame. Post-evaluation for TAV and TAV, which is a very complex subject, but we can clearly see all the areas, the nodes without a skirt up top, the nodes with the skirt at the bottom. You can see the entire ceiling skirt. We can also clearly see the leaflets and try to model things like sinus sequestration. Holography is a newer technology just at its inception. Some people have used it, including my former colleagues at Columbia. You can actually create these realistic holograms on this headset. And you can use this. This is an example of the use of the holography and measurements by the interventionist during the case, combined on top of the 3D TE. So this is not a talk on coronary artery disease, but there's something I want to touch on. Now with things like photon counting technology and all the benefits, we're really entering a new era with CT, which affects both our pre and post procedural imaging. We've been fortunate to get one of the first systems in the US, and we currently have performed the highest volume of cases on photon counting technology for cardiac in the world. And this has impacted our diagnostic segments for coronary CT very quickly and reduced the indeterminate reads to much less than 5%. And we can do all types of cases, including high calcium, stents very clearly seen. Here's some example of mild disease inside stents, which we can now see perfectly. This is in comparison to a typical good scanner where you really can't see inside of it very well. Now, connecting this to what we've been talking about, structural heart, I don't think we would ever go into a structural heart TAVR case without having a pre-CT. So why shouldn't we do the same thing with coronary interventions rather than going in blind? So there is a movement now to kind of catch up with coronaries and really make more of a heart team and really plan the case with imaging, pre-procedural imaging, in addition to the intra-coronary imaging. And in structural heart, the multidisciplinary heart team always includes an imaging specialist, which is the standard of care. But in coronaries, we've fallen behind. In the several descriptions of coronary heart teams, they don't include an advanced imaging specialist. And now there are trials and movements to do something called CT-guided PCI. Here's an example where we're planning out the full case, including plaque morphology, calcium, and the FFR-CT, which is going to be beamed into the cath lab and give you a nice roadmap for doing the intervention. You'll know exactly where you need to go before you even enter the lab. And it creates a whole strategy with which vessel, which segment, what guide are you going to use, the fluoroscopic projections from CT, calcium modification strategies, and even up to which stent and the length. And this is an example of the same case, showing the same lesions in the case. And a very good correlation between the pressure pull factor in the case and the FFR-CT. So in both structural and coronaries, are really there's a confluence now of the advanced CV imager, the interventional imager, and also the interventional cardiologist, operator, and imager. Many interventional cardiologists are now boarded in CT and look at their own structural CTs, and now that's also expanding into coronary CT. So it's really this heart team approach with some overlap on people's expertise. So in summary, we need more imagers to do all of this stuff. It's increasing rapidly at exponential rates, and that really requires support, recognition, and of course, reimbursement. Thank you.
Thank you so much, Omar. Phenomenal talk. We'll take any question from the audience if you have any question or comments to the speaker. I have a comment. Also, I would like to have your input on it, which is tell us about your professional journey. Definitely, you are successful. You are getting top-notch devices because you proved your system that you can deliver, and you are using it. You're proving that there is a proof of concept, or at least there is a need for this technology in your system. Every health system elsewhere, maybe they don't have that budget or the capital because they don't see necessary. So you made something, you created something that made the system believe in you and support you. So tell us about your journey.
Yeah, so my journey was complicated. I knew from fellowship that I wanted to do something in imaging, although I had no idea really what all was out there. All I knew was echo. And then through, the usual combination of work and luck, I met Becky Hahn, Marty Leon. I ended up becoming the first interventional imaging fellow there at Columbia, and then expanding my own interest in CT MRI. Back then, there were very few combined fellowships, so we had to create our own track. So I would ask, this person and that person, will you train me in CT? Will you train me in MRI? And kind of create my own fellowship. So that's how I came through, and it was fun because nobody was really doing it. So doing research and thinking of ideas that people hadn't really done before. So I think coming up in that way organically, I really learned what are the benefits, and I was also with a very forward-thinking group of interventionists. I really grew up in the interventional world more than on the imaging side, reading in echo labs and sitting at a desk reading CTs. I was always involved in the cath lab. So I think that gave me a bit of a unique perspective on the overall system and what are the benefits of the imager not only clinically, which we know, but how to speak to the hospital and say the benefits of the imager, even though we don't pull in the money, is X, Y, and Z. Um, so I think that that's really the start, right? Identifying that benefit and support for all of the interventional procedures. Um, and now in my new place, new for the past 3 years, I'm also with a similar forward-thinking group, but we have to prove the benefits. So what we proved was that with increases in coronary CT, there was a fear that cath lab volumes go down, but actually they've only gone up, and the quality has gone up because the efficiency has gone up. Where we've submitted an abstract with our and a paper with our experience on photon counting CT for coronaries. And actually, the cath lab is more efficient. We're doing more PCIs, fewer diagnostic caths, which don't amount to anything. So better patient safety, actually higher revenues because the ratio of PCI to non-PCI is higher. And then the exponential growth of all of the some of the structural procedures, in particular, LA appendage is a big one. TAVR is pretty steady with slow growth. But it's really also teaming up with your interventionist and your structural heart interventionists because they know your value. So it has to be a team effort, right? And discussions about, sharing models and support models. I really don't, I think it's a bit derogatory to always say we're funding the imager because without the imager, you can't do a case of LA appendage, which has a revenue of whatever it is, a TAVR with the revenue, mitra clip, and all of those different procedures that we're doing now. So one is really dependent on the other, I think is the message.
How about in terms of ICE? Is this going to be taking some of the duties that the invasive imager will be doing?
So probably not because you still need somebody to man the ice. I know there are a few operators comfortable doing all of it. I think most are still not for quite a while. So in our lab, we actually have more interventionists in a case than imagers. So there's no way for us to scrub into a case to do ice. We actually have to man the console because the interventional cardiologists don't know how to do it, right? So 3D NPR, all of that manipulation is still the same with 3D ICE, and that's all done on the console. And that's not in the training set of an interventional cardiologist. Manipulating the ICE is, but somebody still has to do all of that. I mean, you could get a sonographer potentially, but it's pretty high level for most sonographers. And it's also the decision making. So you're not just it's not just a modality, you're getting a person, right? So I train with Becky, so I'm pretty bossy. So I tell them what to do, right? I say, move here, move there, do this, do that. So they're literally following my instructions. And if I wasn't there, that they wouldn't have that input.
That's right. In terms of the structural heart interventions are evolving really quickly. You show us some cases of the mitral, some cases of tricuspid, and now we have tricuspid valves. For somebody like doing exactly what you are doing now, how they can keep up with that after graduation? I'm assuming during your training, you never come across a tricuspid case or mitral valve replacement valve. I'm assuming this is something you picked up during the job. How people can keep up with that?
So that's a good question. Are you asking about how do imagers keep up with it or anyone?
Yeah, imagers. Yeah.
So it's in the interventional imaging training set is learning how to learn. So it's not just that you're learning TAVR, you're learning LA appendage, you're learning mitral, and then you finish fellowship and you don't know anything else. You're learning how to learn. So as the interventional imager, you don't just look at a study. You need to know what is the device, how does it work, what are the ancillary things associated with it, the wires, what are the sizes. So it's almost knowing as much as the interventional structural cardiologist about the entire device and the system. And then it's iterative, right? So we also know the imaging part. And then it's iterative after that. Once you've done a bunch of it during your training or job, then you know how to do it again. So I just gave the example. We started our tricuspid cases. We have some younger, well-trained imagers, some of whom we trained ourselves. And they got a training of a few hours or whatever it was, and they were doing the device they've never done before, and they did a perfect job. And because they know how to incorporate the learning of a new device. They do the training, they even deploy the device on the bench. They learn everything about how it works, and they're able to image it and understand and do the case. So it's a big part of the interventional imaging skill set is learning how to learn new devices.
And usually they go to centers like yourself, for example, where you do high volume, they come and kind of get proctored or watch these cases. Is there an opportunity for that as well?
So there is some of that. I think a lot of the training is through the vendors. I am disappointed that the vendors don't use more imaging proctors for their cases. So I think that's a big issue. So if they bring out an interventional cardiologist to help you do your case, and then the person they have proctoring your imaging might be a sonographer, right? So it's a different level.
That's right.
I think the imaging proctor, whether it's proctoring going out or reverse proctoring, like you mentioned with the person coming in, and is an extremely important and very neglected aspect of the whole field right now.
And just final comments about you mentioned in your first slide you are director of the invasive imaging at the Catholic Hospital. Can you tell us about it? When did you start, and how many fellows you take, and when the application opens?
Sure. So I direct all of the imaging programs. Lynn Wong is actually our director of interventional echo. But we're a 6-hospital system. We have a footprint for interventional imaging in 2 of the hospitals that do cases, CT and MRI beamed in from most of our system. We have 2 tracks, 2 years. One is a year of CT MRI where you get level 3 in both modalities, and we take 5 fellows. And then we have 1 interventional echo imaging fellowship slot per year. I'm hoping we'll expand to 2 in the next couple of years, which is also a 1-year track, and with the opportunity to do some PET imaging as well. Since this is non-ACGME, as I mentioned, it's a rolling admission. There's no deadline. So it just depends on when we get candidates for the year in question. But also because it's not a match, you get candidates pretty early who are interested, sometimes 2 years ahead of time. So we fill up as soon as we can. But for 2025, we still have 2 slots available if anyone's interested.
Well, again, this is a plug for the fellowship with Dr. Khalique. I mean, you hear the great stuff that he does, from echo to CT to all kind of multimodality imaging. Omar, thank you so much for your time today. Really, it was a very enlightening and eye-opening presentation about the potential of imaging and how important it is for planning, not just for structural heart, but also you touch on coronary and PCI intervention. This is again the presentation, and the webinar will be recorded and hosted on the Facet website. Thank you for everybody who joined us today. Again, join us next month. We come to you every third Thursday at 6 p.m. Eastern Time, 5 p.m. Central Time. Dr. Khalique, thanks so much for your time today, and congratulations for a very well done and successful program.
Thank you, Chadi.
See you in TCT.
All right, take care.
Take care.